Thank you very much, and welcome to Copenhagen, to this PCI that we will do today. For many reasons, it's an interesting case of what could seem to be just a simple focal stenosis, but there are a number of issues to take into account. It's a 76-year-old male who is predisposed to ischemic heart disease by hypertension and hypercholesterolemia. And of note, he has no angina pectoris. The main symptom is dyspnea, New York Heart Association class 2 to 3. And this is due to a severe aortic stenosis with a peak gradient of 66 and a valve area of an open area of 0.6 square centimeter. Left ventricular ejection fraction is reduced to 35%. The angio has shown us that the patient has a chronic total occlusion of the right coronary arteries, and in addition, a focal stenosis on a big circumflex, which is preceded more proximally by a more intermediate but also quite severe stenosis. And you can see that in the picture. So, of course, a number of questions arises. First and foremost, the main problem for this patient is the aortic stenosis. This is planned to be relieved by means of percutaneous valve replacement, TAVI. And we are often discussing at our institution whether we should revascularize these patients or not, because if no angina and if no prognostic coronary indication, you could leave the patient with only the aortic stenosis treated. We are at Rigshospitalet conducting a study called the Notion 3 study, in which patients with aortic stenosis eligible for TAVI are randomized to revascularization in one of the arms and conservative treatment of the coronary arteries in the other arm. And we have actually, in a multi-center setup, finalized the inclusion of the patients and will obtain the results in a year. So until that, we have to make a decision from patient to patient. The FFR value beneath the distal lesion is 0.62, so we have definite ischemia. And Lene, maybe you can show us the IVUS so to get a little bit of a better impression of what vessel we are talking about.
Yes, let's start with the setup shots here, and we can see a quite big, quite large circumflex with the proximal stenosis and a stenosis distal to the marginal, and we have it in several projections. We also have the LAD, and actually we had an FFR of the LAD 4 weeks ago, and that was 0.84, so not significant. And you may also recognize collaterals to the chronically occluded RCA. And this is just another shot. Actually, we had to dilate the distal stenosis a little bit before we went on live, just to be able to do the IVUS. So let's have a look at the IVUS here. Yeah.
Oh, yeah.
So now we are a bit proximal. We have to start over in a little while, and we have to move this. So yes, let's just leave it for now, and we'll start from the beginning. This is the left main. And let's start over here. Quite a large vessel with the stenosis is the distal stenosis and the marginal branch. Then we have a short segment without significant disease. And in a minute, we will move proximal into the calcified lesion. Quite short but very calcified lesion, 360 degrees calcified. And then again, a large vessel with less disease. So you can see here the size of the vessel proximal to the stenosis is 4.4 millimeters between the two lesions, 4 millimeters just proximal to the distal lesion, 3.8, and distal to the most distal lesion, 3.6. So a large vessel. And we were just discussing the best way to modify the calcium. What do you think, Thomas?
Yeah, well, basically, we have four modalities. We have at the conservative end, high pressure balloons and scoring and cutting balloons. We then have shockwave, which by means of ultrasound pulses cracks the calcium. We have rotablation and we have orbital atherectomy. If you have calcified, ring calcification, 360-degree calcium, then the propagation of ultrasound will be reflected within this ring and very effectively crack the calcium. So shockwave is very effective. But having said this, the size of the balloon is quite bulky, so you need to be able to
advance the balloon.
To advance the balloon before doing shockwave. I think this is perfect for shockwave if you can advance the balloon.
Yes. So we have prepared the shockwave for today, and we will proceed and try if we can advance the balloon and dilate the most proximal calcified lesion.
So when we consider whether to do these TAVI coronaries, of course, we look at the severity of ischemia, the territory involved, and in this case, we find the circumflex to be quite a big territory, but also, of course, the supposed complexity of the procedure. If it's not too complex technically, we would rather go for PCI than conservative treatment. So it's resemble perfectly patients without aortic stenosis. We did a cohort in which patients had both non-hyperemic index done and FFR done before TAVI and after TAVI, and it showed that FFR is much more stable before and after TAVI. In other words, you can rely much more on the FFR value to discover ischemia than the IFR or RFR. So we always use adenosine-induced pressure measurements in our TAVI patients.
Jeg den kan først ikke gå ind. Vi kan, ja, vi tager den lige ud igen.
Har vi rota stuenes der?
Ja, vi har også rotaen her. Jeg tror lige, vi må lige prøve den ud. Jeg vil ikke rigtig gå ind i den her. Jeg tror, vi kan få den et stykke ned i hvert fald.
Ja.
So as you notice, the bulkiness of the balloon is always a problem, and sometimes you cannot advance it into the guide extension. So we'll try once more without the guide extension.
Er du frisk på rosa, hvis der er vi...
Ja, selvfølgelig. Ja, vi kan lige kigge i også en 7'er. Den er jo ret stor, den her, så.
Er det ikke også 2 timer?
Jo.
Jeg synes, jeg går og kunne lave en rosa.
Vi kan også tage en, hvad hedder det, en højtryksballon ned først, jo. Det kan vi også godt gøre. Vi vil prøve det først.
Ja.
Lad os få en emerge. Lad os starte med en 3.0.15. Den der runde vil bare være ret god, den der kalk der.
Ja. Og meget cirkulær kalk var der oppe i den proximale version.
Jamen, det er kun der.
Det er kun der?
Det er kun i den proximale, du kan se her.
Der var ikke i den distal?
Nej.
Nå, okay.
Det er kun her. Det her er den proximale.
Okay, den er i hvert fald.
Ja. Så det er kun den proximale. Nå, så må vi skifte den ud. Yes.
Ja. Nu kommer vi ikke til at elske den der Godzilla. Vi kommer ikke til at elske Godzilla nogensinde.
Nej, ikke den. Yes. Starter vi lige med den her.
Okay, so we go for a high pressure balloon to create more space for the shock wave, and if that does not succeed, then we will consider rotablation.
Yes. So this 3.0 emerge, it goes down very easy. Henter en ny shockwave ballon. Ja.
Det er så fint.
Ja, det må man sige.
Hvor stor en shockwave skal vi bruge?
Altså, jeg har bestilt en 3,5.
Ja, god idé. Ja. So, I think there will be space now for the shockwave. One thing to consider is, of course, the size of the shockwave and the effectivity of the ultrasound pulses is only big if you have a position of the balloon to the calcified wall. This means that you should take a balloon that occludes the vessel when you deliver the shocks. And in this case, we have chosen a 3.5 balloon shockwave. And the purpose of the shockwave balloon is not to high pressure the lesion. It's merely to deliver the pulses. And therefore you inflate the balloon only at very low pressure, 4 atmosphere, to secure a position to the vessel wall when you give the pulses. After you've given the pulses, you expand the balloon to 6 atmosphere to see if it expands fully.
Ja. Tager lige en 3,5 ml.
But already now there is a good effect of the balloon.
It looks better.
We use more rotablation than orbital atherectomy at our institution. I know that's probably the case in many hospitals. But rotablation in some cases do not give much. If you have a big lumen and you have protruding nodules into the vessel, the rotablation may just repel from the nodules and not really crack them or make them small. And in that case, orbital atherectomy could be a good alternative.
A nice expansion of the high pressure balloon. This is a 3.5.
So this could indicate that although it's a ring calcification, it's not that thick. You can also realize from the IVUS that behind the ring calcification, you actually see tissue and you see reverberation of the calcium signal. And this means that the calcium is probably quite thin. Jeg tror faktisk, det er Frances telefon, jeg har fået ned. Jeg tage den.
So the patient is feeling fine? Yeah. Great.
Frances telefon ned, han er vagt. Så har han så min.
Yeah.
Det gik lidt stærkt, vi havde et ret dårligt patient.
Ved du hvad, vi går lige ned med den her, og så måler vi ACT. Hvad siger du, Per? Ved du hvad, Janni, hun er lige nede i den anden ende, så kommer hun og hjælper. So now it moves much better than before. So the pre-dilatation was definitely needed. Yep. So now we are ready. And I'll go to 4 atmosphere and please go on with the shockwave. And then to 6 atmosphere. And then negative.
So, and at 6 atmosphere, the notice is really whether the balloon expands at low pressure, because this means that you have broken the calcification. We do 10 shocks each time.
10 shocks.
And each balloon can give you 120 altogether. And although the balloon already is fully expanded, we give some more shocks to add micro cracks along the circumference of the vessel to secure that the stent will expand perfectly.
Nej, ikke dem alle sammen. So we'll just continue doing a few more shocks here. So the ring calcification was really localized in a very short segment. So we'll just keep on doing the shocks at that place.
So we often discuss whether a strategy should be each time upfront rotor if you have calcification, and then subsequently shock wave. And we quite often do that actually. But it's more cumbersome, and it also often creates more stress to the patient with the aortic stenosis and low left ventricular ejection fraction. And
we'll do the final one here.
We wanted also to show the efficiency on circular calcium with the shock wave.
So we could do, should we do just a compliance check with a 4-0 balloon in 4-0-20 træk? Just with a low pressure to see the expansion of the balloon. And then an IVUS afterwards, yeah. Yeah. 4-0-20 Artemis, yeah, fint.
So now Lene will do a compliance check with a 4mm balloon, and then we'll do an IVUS to see how we have prepared the vessel before standing. We will also measure again and make a decision. We also need to predilate the distal stenosis, which had actually very little calcium.
And of course, very important to remember also during live cases to check the ACT, so we can give more heparin if needed.
We check ACT on a regular basis each 30 minutes and aim at 250 to 350. Now, the clinical challenge in patients with aortic stenosis, coronary artery disease, and reduced left ventricular ejection fraction is, of course, hemodynamics. Our patient is stable all the way, high saturation, good blood pressure, and sinus rhythm at 62. But you realize that each time you dilate in the coronary artery, you apply a little bit of ischemia to the myocardium. And sometimes if you move on too fast, the ischemia is not relieved from one balloon to the other, and you kind of accumulate ischemia, and then hemodynamics can fail.
So this is with low pressure, 6 atmosphere. And we just need to move a little bit below here, just to check again. Right. Too much.
So we're not in a hurry.
No.
And if we see pressure drops, then we fully wait until pressure has recovered before continuing. We also sometimes, if the patient is very fragile, do lactate measurement every 30 minutes along with the ACT.
So I think we see a pretty good expansion in 2 different angles. So we will remove this semi-compliant balloon and then do IVUS. Yes, just go ahead, Thomas.
Yep. Yeah, and as long as the lactate is low, a patient is fine. And we think that it's important that you build in these logistics as on a routine basis.
Så giv 2000, Janni, og tjek igen om en halv time. Retten på live. Vil du lige at understøtte den? Tak. Det er den distale stenose der.
Ja, der er bare lidt. Det var vel faktisk meget fibrøst. Kaldte det op toppen. En 3,5. En 2,5.
Ja. Og lige 3,8. 3.8 distal.
Okay.
So we will soon move into the area of interest.
Vi ikke kommer med hovedstrøm.
Der kommer hovedstrøm der.
So I don't know if you noticed while we scanned across the lesion, we have now multiple cracks. We have no longer circular calcium, but instead plates of calcium, indicating that the ring has been disrupted. So we expect to be able to expand the stent now.
So let's have a look here. We can go with IVUS 2 here. So we just started just distal to the distal lesion. Not that much.
For the distal lesion, just
here. We can measure the diameter. 3.8. 3.4.
This is visualization. Der for eksempel.
Yeah.
And here you can see in the lesion that you don't have this very high attenuated calcium, except there is some calcium from 8 to 11 o'clock. But since the rest of the vessel is without calcium, we expect a stent to be fully expanded, and the calcium will just be moved outwards when we expand the stent.
So we see crack here and here in the calcium, and here where we had these ring calcification. But also what is interesting is this. I believe that's the hematoma in the wall after the dilatation. So, but we will cover this with a stent in a minute. Don't you agree, Thomas? This must be the hematoma, and we also here have cracks in the calcium. And still, this is also a hematoma.
Yeah. And the hematoma you can also see in the longitudinal view.
Yeah.
As a gray
down
white.
Here.
Yeah.
So we'll probably have to go almost to the ostium to cover this.
Yeah.
So let's see here the diameter.
So when we measure an IVUS diameter, we measure media to see what's the size of the vessel. But if you have a big plaque burden and you need to stent over that, we will also measure from lumen to lumen. Because if you have a big plaque burden and try to expand the stent to media size, then the vessel at the side of the plaque will be very big. So often if you have big plaque, we take a diameter which is in between media to media and lumen to lumen. And that's kind of calculation from patient to patient. So, yeah.
So we could...
Dilaterende distal?
Yeah. Skal vi bede om en 2,5 emerge, 2,5-15 lige til den distale.
Ja.
Men ellers så kunne vi stænde det med en 3,0 der,
33,
og så en 33 proximal.
Ja, det kunne vi gøre. Nå ja, nu kan jeg se. Ja. Sorry.
Derfra, ikke? En 3,018, og så en 3,0 eller en 33, ikke? Nogenlunde. Sådan der.
So the plan now is to the diameter of the vessel distally is 3 point something millimeter, but it's not 3.5. So we will take a 3 millimeter stent, 18 millimeter long.
Yeah.
And then we will, in addition to this, take a 3.5 times 33 millimeter to cover the rest of the vessel.
Ja, tak.
We use the longitudinal view to measure the lengths of the lesion.
3,018 sides.
It can be a little bit inaccurate because there is motion of the vessel and the ultrasound catheter at the same time, so length measurements can be inaccurate. Diameters are often always very accurate.
Mm. 3,018 science skal vi have distalt, ja.
So regarding the hematoma, that's not always very pleasant, because when you expand a hematoma, it can move distally approximately, but often you're able to cover then the occurrence of cracks and hematoma actually tells you that it's a very well prepared vessel now for stenting. Og et stort hematom.
Ja. Så er vi lidt mere vise på IVUS'en.
Ja, det er fint.
Ja, tak.
And yet again, we take all the time we have. Recall that there's a chronic RCI occlusion and we have a relatively big circumflex territory. So if we are in trouble, we have a big territory altogether that can give us hemodynamic challenges.
Træk den lidt længere tilbage. Vi sætter den der.
Lad lige se vores relation.
Sad lige efter der.
Ja, det kan vi gøre.
Jeg tænker, det er meget fint der. Hvor den atmosfære.
We had good landing zones. A good landing zone is a landing zone in which you have less than 50% plaque burden.
3,5-33 science.
And distal to the distal lesion, we have virtually no plaques, so perfect landing zone.
Skal vi lige se, hvor vi kan få en stent boost.
Ja, det er også meget lige at vise. Det er den der coronary tools. Hvis du klikker på den her tes.
Den har han ikke, så vi må
jo, prøv at klikke på den. Står sådan der. Så jeg kan løfte den op der.
Løfte op i den der.
Ja. Perfekt.
Sådan der, ja. Ja, tak. Så må vi se, hvis den er for kort, så tager vi bare en 38. Ja.
3 timer i streg.
Ja.
Nu Springsteen. Helt ondt i benene. Ja. Det er godt lige nu. Det er meget okay, synes jeg. Nu er du ikke helt ekspederet, du har sat den også bare ved 14.
Jeg har sat bare ved 14, ja. Nu må vi se lige på,
så gør vi det stille og roligt færdigt.
det passer på længden her, ikke? Ellers må vi op i en 38. Det kan godt være. Ja. Bare vent med at lave undertryk. Det var vi lige. So we just need to measure. Jeg kan godt gå lidt tilbage. This is we're stent boosting, but it's probably a little too short, this stent.
Ja, vi vil nok godt have dækket det ret godt, det der hematom, så vi får det squeeze op i hovedstammen.
Skal vi, this is a little bit too short, so we will take the stent out. And we would like 38 instead.
So we use the stent boost to see the orientation of the stent in relation to the first stent. And there was a minimal overlap, but we missed a few millimeters on the proximal. So we take now a 38 instead of a 33. So that's an example of where IVUS miscalculates a little bit the length.
Yeah, or I put the distal stent a little bit too distal.
Yeah, it could also be.
Because it was the numbers were just exactly fitting. So maybe it was a little bit too optimistic to go with the 33. Du siger 3,5-38. Ja, tak. Du har den. So this is the proximal part, and we'll take the stent boost. So maybe it just 1 millimeter forward.
Det passer også meget godt op til op.
Ja, det tænker jeg også.
Lige en millimeter til. Ja, det er god.
Er vi langt nok proximal? Nu er vi i hvert fald we're at least 2 millimeters inside the stent.
Så også det var? Eller hvad? Må tage en film.
Ja.
Det synes jeg godt.
Jeg vil sætte den der. Vi stent booster den lige igen, for at trække lige lidt i den. Ja, we're still within the stent. Okay. 16 atmosfærer.
Nu er vi vel egentlig på det.
Ja.
Er det 4 mm kaprox?
Ja, det er i hvert fald 4 mm. Så en 4.0 emerge. En 0.15. Så tager vi 3,5 distalt. Bare ind i stenten, ikke?
Jo.
Deroppe er den. Ja, 4.
Ja,
4,2, ikke?
Ja. Jeg tror, jeg vil holde mig for kanten. Det er ligesom om, den er plak op i ostet.
Ja, så kun indenfor. Mærker du noget til det, Per? Nå. Nej, det er fint.
Så skal vi hele vejen ned til proximal for marginalen, ikke? Alt i alt.
Vi bliver der.
Ja.
Ja, tak. Ja, tak.
So the vessel was 3.3 millimeter medial to medial, so we have taken a 4 millimeter balloon and post-dilate at 16 atmosphere.
Jeg vil lige, hvor marginalen den er her.
And this goes all the way along the vessel until the marginal branch. So it's kind of a long pot.
Så har vi været oppe.
Ja. Eventuelt så kan man tage kanten bare med 2 atmosfærer, bare lige for at sikre sig, at den har en rigtig diameter. Nu er ude for at plakke for meget deroppe også.
So we want to take a little bit care of the proximal part because we know there's a plaque up here. So now we are outside the stent and we just dilate to like 2 atmosphere.
4, so.
4.
Yeah. So this is just to oppose the edge of the stent to the vessel wall and not trying to expand it in the plaque that is located in the ostium of the circumflex. So it's not an ideal landing zone proximally, but it's okay. Main issue here is to avoid dissection retrograde to the left main, but still secure that the stent is opposed.
Okay. And then we'll move on with 3.5 emerge for the distal part of the vessel. And again, we will use the stent boost just to make sure that we are inside the stent. It looks nice here. Just a low pressure for the distal part. And then a few millimeters back.
Du kan måske lave en IVUS bagefter.
Ja. Okay, so we will move on with the IVUS, don't you think, Thomas?
Yes.
So the ostium of the marginal branch is a little pinched, but the flow is completely normal. So let's take a look at the stent apposition. Der skal jeg trække lidt der.
Jeg skal vise dem, hvordan vi krøller det. Yeah, so often the ostia of side branches can be a little bit pinched when you stent over them, but very often also there's a little bit of edema and it will resolve within days. If you, in bifurcations, go for one stent strategy, then the main focus should be on that you have TIMI flow 3 after you have crossed the side branch with a stent. Then all is happy.
A little bit more distal. We want to be outside the stent before we start the pullback. Yeah, the distal stent area looks quite nice. And that was the side branch ostium that we just passed.
And we look after three things: expansion, apposition, and dissection. En lille smule uviden dernede distalt, kunne man give den et lille tryk med 8 mm, eller er det ok, hvis vi har et stort MSA?
Jeg synes, det er stort, ja.
Men vi kan jo lige vise det, så kan vi jo lige forklare det der med MSA, hvordan stort det skal være. Det er dernede 5 mm eller sådan noget.
Altså du tænker lige indenfor i den distale stat, der hvor vi egentlig var nede med 3,5, ikke? Ja.
So we have a perfectly expanded stent everywhere. At the distal stent, there's a little bit of potential under expansion, but we will now look more carefully.
So this is the area distal to the stent. Let's have a look at the area here. So the area is 12.6. So you're concerned with here, Thomas?
Yeah, it looks a little bit over it.
Here it's definitely fine.
Yeah.
Okay, so let's measure here the area. So this is 8.5. So compared to the distal part, it's a little bit too small. Yeah. But we went with a 3.5, so maybe we should actually go with a 4, because I mean distally the diameter is actually 4.
Ja, så skal
What
det
do
være
you
8
think?
millimeter, ja.
Ja. En 4, ja, eller bare en 15, det gør jo ingenting.
Ja, det er fint.
Ja. En 4015, en frisk 4015 emerge. So while we're waiting for the non-compliant balloon that's go up, do you have any more comments on the stent here, Thomas?
Looks perfect there.
So now we are definitely where we had all the calcium, this area here. Then we had the area with the edema. And then we have proximal to the stent.
Der er ikke nogen dissektion, vel?
No. Yeah.
So we look very carefully at the proximal stent edge,
Yeah.
which was at the ostium of the circumflex, to see if there's no dissection, which we cannot see. And then in the part where we did the shock wave, the stent was also a little bit ovoid, but then to go further to perfectly circularize the stent could also mean that we take a risk of perforation. We all
because we have a lot of
hematoma.
very, I mean, sharp, probably calcium in the vessel wall. So I don't think we should go any further.
No, we would not
in that
challenge
area.
that. Yeah. You have a good minimal stent area there. And we already have a hematoma, so we will not challenge the vessel more there.
Only in the distal part, yeah.
Ikke for super højt tryk dernede.
Nej.
Måske også noget pjat der, ikke?
Den er lidt svær at få ned, faktisk. Vi ser, hvor den er. Det var lige ved marginalen, ikke?
Ja.
Nej, faktisk er det distal for den.
Måske også der, den var lidt ovoid der, fordi den
ja, det er den. Nu er vi dernede. Nu skal vi bare lige... Vi skal i hvert fald lige inden for døren i hvert fald.
Ja, måske lidt højere op, fordi det første stykke var den så set vel ekspanderet. Ja. Så nu går op, så du kan faktisk se det på stentbussen, hvor det er.
Og det fik jeg ikke lige set. So, take a look at the stent boost. No, we need to go more distal, right? A little more distal.
Der.
Jamen, den er faktisk lidt svær at få forbi der, så det kan jeg godt forstå.
Det er ikke meget godt, jeg tror, du dækker det der stykke.
Kan du se det, Thomas?
Ja, det tror jeg, den går.
Ja, det er lige den distale ende der, er det ikke det?
Jo.
Okay, så skal vi ikke.
Så jeg skal vi kunne nu ikke under herrekarret alt for meget.
Ja, du skal heller ikke gå alt for. Så 12 atmosfære fik den her. Was actually just over the lesion. Ja, det blev sådan 4-0 i stedet for. Ja, distalt. Skal vi lige tjekke ACT, og så tak. So the patient was already on aspirin and he was loaded with clopidogrel before the procedure and will continue on clopidogrel and aspirin for 6 months.
Det holder tabifolden dem også på, ikke?
Hvad siger du?
Det holder tabifolden dem også på, når de har
ja,
tabi. Ja,
det mener jeg. Jo. Det var et single shot. Yes. So I think this is it. We are almost done. Just take a few shots without the wire. How much contrast, Jenny? Or Nina? So 100 milliliters of contrast used. So I think this is it.
Yep.
Here from Copenhagen, and I would like to thank the nurses Nina, Jonas, and Janni for helping us out today. And I think this is it from Thomas and I. And thank you for watching.
Thank you for watching. Goodbye.